Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com. Simply an email will get you access to a 31-page PDF on the top 200 drugs. It's a great little study guide, great refresher if you're out in practice. Definitely a no-brainer to have, and simply an email will get you access to that. And we also get you updates when we've got new podcasts and other content available as well. All right, the drug of the day today is desmopressin, also known as DDAVP. And covering the pharmacology, mechanism of action here, its classification is a synthetic vasopressin analog. And if you remember, vasopressin basically equates to ADH, or antidiuretic hormone. So desmopressin is actually going to cause the reabsorption of water. Think antidiuretic action, basically, is the easiest way I remember that. So synthetic vasopressin analog is what desmopressin is. Now, your body actually produces this, right? It's produced in the hypothalamus, ultimately released from the pituitary gland, and vasopressin is that hormone that increases water retention in the kidneys by promoting the insertion of aquaporin water channels into cell membranes. And this hormone's purpose is basically to help maintain adequate blood volume and blood pressure. Okay? So mechanistically, what does this medication do? It activates vasopressin 2 receptors on collecting ducts, which again ultimately increases cyclic AMP, which causes an increase in the insertion of those aquaporin water channels. This leads to water reabsorption and a reduction in urine volume. Okay? It also causes an increase in urine osmolality. Okay, so basically, water is going to come out of the urine, go back into the body, or it's going to be prevented from going into the urine and the bladder, and it's going to go back into the body. But some of the solutes, specifically like sodium, will actually stay in the urine. Actually, it'll become more concentrated urine. Mechanistically, it can also trigger endothelial release of von Willebrand factor and factor VIII. This improves hemostasis in type 1 von Willebrand's disease and mild hemophilia as well. Okay, so getting to those indications, and probably the primary thing I'm going to focus on is primary nocturnal enuresis, so involuntary bedwetting in kids, as well as nocturnal polyuria in adults as well. And this medication was actually prompted because somebody was using it in a geriatric patient of mine. And so I wanted to kind of give you the rundown of this medication. The other indications, hemophilia, central diabetes insipidus. So remember, with diabetes insipidus, we've got that excessive urination and excessive thirst. Again, so if we're causing reabsorption of water, that can potentially help reduce that excessive urination. So there's a big reason why you don't see this medication used very often. It had been a long, long time since I had seen it for the use of, bedwetting and frequent urination at night. And there is a boxed warning with this medication, and that's really why you don't see it very often. And I'll get to that boxed warning coming up here. First, cover dosages, dosage forms. We've got oral tablets. That's mostly what you're going to see. Also got sublingual tablets as well. 0.05, to kind of in the neighborhood of 0.2 grams is kind of the starting usual dose. Can go up to 0.8 milligrams per day in 2 to 3 divided doses. Again, depends upon the indication. Usually, we're probably going to be in the lower range of that dosage range, particularly in the situation that I had in trying to reduce polyuria at night. There is an intranasal formulation as well. I'll mention that. So, yeah, we do have some options here with this medication, the way it can be delivered. All right, so adverse effects, boxed warning. So, gotta pay attention to sodium. That is the most important thing, I think, to note. Definitely something that could come up on a board exam or pharmacology exam if you see a question asked about desmopressin. It can drop sodium levels, right? Which makes sense. If you bring more water back into the body and sodium isn't coming with it, then we're potentially diluting out that sodium and it could drop to dangerously low levels. So, sign of hyponatremia, you may hear the term water intoxication as well. Headache, nausea, CNS changes like confusion, seizures if that sodium gets low enough, coma if that sodium gets low enough. And obviously there's risk factors for this as well. And, elderly is obviously one of those patient populations, as well as poor renal function, excessive fluid intake. Okay, so there's a few different risk factors here. Also some medications, which I'll talk about in drug interactions, that can increase that risk as well. Other potential adverse effects, obviously nasal irritation with that nasal formulation, as well as nosebleeds and congestion and irritation there. Some other things you may see: headache, flushing, some stomach upset, those type of things. Rare, maybe a hypersensitivity reaction and that type of thing. But hyponatremia, definitely the one that you absolutely want to remember, and we're going to need to monitor those sodium levels. So, associated with that, contraindications, hyponatremia, or history of hyponatremia. Renal impairment, we got to be careful with. SIADH, we definitely got to be careful with as well, with pre-existing diagnosis of that. And then some of those drugs that I mentioned, loop diuretics, for example, SSRIs. Those are things that we really need to be cautious of, be aware of, that may further increase that risk for hyponatremia. Also pay attention to folks who are kind of predisposed to fluid electrolyte imbalances. So obviously elderly I mentioned, but patients with heart failure, there's another good one where that fluid status can maybe kind of fluctuate a little bit. That may cause for a little bit more variability in the electrolytes of that patient and may put them more at risk for something like hyponatremia from this medication. Monitoring parameters, of course, we got to monitor that sodium baseline, and then usually, maybe at 1 to 2 weeks, and then monthly after that, kind of depending upon what we're doing with the dose, how stable they are, do they have other risk factors and things of that nature. A couple things to mention on the pharmacokinetic side. That onset of action with, oral, for example, is relatively quick, within, an hour or so, give or take. As you could expect, if we're trying to dose this medication at night, to reduce frequent urination, for example, at night, that's a situation where it's like, yeah, you want that medication to obviously work quickly. Now, again, we do not like to see this medication used, ideally very often for this, particularly in older patients. I get pretty nervous about it due to that risk of hyponatremia. But if we're using it for that purpose, for problems at night, we definitely want to make sure that that medication is working at the time of taking it and using it in the evening there. The other thing I will mention is elimination. This is significantly eliminated through the kidney. So patients with poor renal function, that is definitely a significant risk. Obviously, concentrations could rise if you give this medication to a patient with worsening renal function or with poor renal function in general. The concentrations may be higher than we realize or than we want. So really important, pay attention to that renal function with this medication. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study materials like BCPS, BCGP, ambulatory care, BCMTMS, or NAPLEX, go check out meded101.com/store. We've helped thousands of pharmacists pass their board exam, and we can absolutely help you too. So your support there directly goes to help fund this podcast. I greatly appreciate that support. Again, go check out all those links, meded101.com/store. All right, wrapping up with drug interactions. So first and foremost, I think about other medications that could lower sodium. Okay, so a lot of the antidepressants like SSRIs, SNRIs, TCAs, MAOIs, they have been associated with SIADH, which can cause hyponatremia itself. So adding desmopressin on top of some of those medications, that could increase that risk. Anti-epileptic, anti-bipolar type medications, carbamazepine, oxcarbazepine, two medications, again, that can cause hyponatremia on their own and could definitely have some additive type effects. One that I have seen come up on pharmacology and board exams throughout my career is chlorpropamide. This is an old sulfonylurea medication. It's been quite a few years since I've seen it actually be used in practice, but I did want to mention it specifically because I know I have seen it come up on pharmacology exams, at least throughout my career. So again, that's an older sulfonylurea type medication that can cause SIADH. And then, of course, we've got to think about diuretics. Any type of diuretic medication that can cause hyponatremia can have that additive type effect with desmopressin. So any type of the loop diuretics, thiazide diuretics, those are great examples of commonly used medications that could exacerbate that hyponatremia effect. Also, glucocorticoids are associated with hyponatremia as well. So that's one to pay attention to as well. All right, reduced response or potential opposition type action. So lithium can actually induce nephrogenic diabetes insipidus. So that's kind of the opposite type effect of what we're trying to do. So if we're using desmopressin for diabetes insipidus, medication like lithium may kind of counteract or directly oppose that effect. Another one, dimeclocycline. So this is actually a tetracycline antibiotic. It's been quite some time since I've seen this medication used, but I have seen it used for SIADH many, many years ago, patients that had trouble with their sodium levels. And this can actually antagonize the effects of vasopressin. So basically antagonize the effect of desmopressin here. And then one last one I'll mention here is alcohol. Obviously, significant ingestion typically causes patients to have to go to the bathroom more, kind of opposing the effects that we're trying to, the potential beneficial effects that we're trying to have with desmopressin. All right, well, I think that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor, leave a rating, review on iTunes or whatever platform you're listening on. I greatly appreciate that. Of course, go to meded101.com/store. We've got stuff for nurses, stuff for pharmacy technicians, stuff for pharmacists, pharmacy students, anybody you can think of that can benefit from pharmacology education. Tons of stuff there, meded101.com/store. Go take advantage of that and support the sponsor. If you want to reach out to me, comments, suggestions, questions, mededucation101@gmail.com. Or you can track me down on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. Thanks so much for listening. Take care, and I hope you have a great rest of your day.